another session. Okay, so I hope you can hear me. Okay, so today we would be continuing with the endocrine disorders. Okay, so we had began with diabetes mellitus. I mean, we covered diabetes mellitus. So one of the endocrine disorder, and today we would be focusing on the remaining aspects. Okay, yeah. So I would be sharing my screen now. Okay, so as you all know, so this endocrine system, the glands associated with the endocrine system. So how many glands are there? So there are almost around 8 to 9 glands that usually that is basically needed for regulating the hormones. Okay, so now here coming to the endocrine system, as I had already mentioned in the previous gland. So what's the master gland? So what's the master gland? Did I? Yes, pituitary, isn't it?
Pituitary.
Yes, very good. So pituitary is the master gland, right? So this pituitary gland itself will be helping in releasing. See, this pituitary itself is having two parts. One is anterior and the other one is posterior. Okay, so anterior and posterior. So the anterior secretes so many hormones. You can see here, like prolactin, growth hormones, mainly growth hormone, luteinizing hormone, FSH, ACTH, TSH, and so on. Okay, so these are actually secreted by the anterior hormones. Okay, so where I mean, so the anterior pituitary. So the hormones that are secreted so are from anterior pituitary, and whereas the posterior secretes the other hormones, like you can see here, oxytocin and vasopressin. So they are the major hormones that are secreted by the posterior. Okay, so oxytocin and vasopressin. Now, coming to the disorders of the pituitary gland, I would be talking about these hormones and also how it would be helping out. Like the first and foremost is the thyroid stimulating hormone. So this thyroid stimulating hormone is basically responsible for regulating the thyroid hormones, okay, TSH, that is secreted by the pituitary. Gonadotropic is responsible for growth related effects, okay. So prolactin, mammary gland, like I mean, so secreting milk, okay. So then, of course, GH, growth effect, adrenocorticotropic hormone, so which is otherwise called as ACTH, it will be actually directing the adrenal cortex. Do you know where are these adrenal cortex present? Yes. Where is this adrenal cortex present? Any idea?
Above the kidney.
Kidney.
Yes, adrenal
Kidney.
glands are present on
Above the
top of
kidneys.
kidneys. Yes,
Above the
exactly.
kidney.
Exactly. Okay. So now we would be discussing about the details of these glands later, but I just want you to understand the different pituitary glands and how they are actually acting on. Okay. So adrenocorticotropic act on the adrenal glands. So that will stimulate its effect in controlling the electrolyte balance and all. Okay. So like fluid and electrolyte balance maintenance usually happens from the adrenocortic hormones. Fine. Okay. So please have a look at this. I would be getting back in a minute. Okay, so getting back. So these are some of the hormones, as I already said. Growth hormone, increase in growth hormone will be causing gigantism in child and acromegaly basically in adults. Okay, so we'll discuss this later. Whereas decrease can cause dwarfism in child, and apart from that, lethargy, premature aging. Okay, so ACTH, as I told you, when it increases, it will cause Cushing's, and decrease is basically causing Addison's disease. Okay, so ACTH is adrenocorticotropic hormone, which is basically responsible for the glucocorticoid production as well as mineralocorticoid production in the adrenal cortex. Okay, so what do growth hormone, so what's the basic action of the growth hormone? So this is responsible for promoting the growth of body tissues. Okay, so in the sense like for muscles, for bone, for liver. Okay, so this growth hormone is very important. Fine. Okay, yeah. So coming to the next one, TSH. TSH has got the stimulating effect on the release of T3, T4 from thyroid. Okay, so TSH, it basically produces and releases T3, T4 from thyroid. Okay, yeah. Coming to FSH, what's the basic function of FSH? So now here I have given like the increased effect and the decreased effect. Okay, so they are the abnormalities that will lead to various disease conditions. Fine, so or various disorders. Now FSH, when it increases, so FSH, what is the basic role? Any idea? What do FSH? What does FSH do? Yes, any answer?
Regulates ovary.
Ovaries, yes, it is responsible for maturation of ovarian follicles. Okay, for spermatogenesis, it will be helping. Fine, so it is helping for the maturation of ovarian follicles as well as for spermatogenesis. Fine, so now here, if FSH too much increase may not be causing any disorders as such, whereas decrease will be causing infertility, late puberty and all. Okay, yeah. Coming to the luteinizing hormone or LH. LH is basically response, it will act on ovaries in producing estrogen, progesterone. Okay, and also on testes in producing androgen. Okay, and also LHS is required for releasing prolactin, so that is responsible for breast milk production. Fine. So too much increase can cause menstrual disturbance and decrease can cause amenorrhea and impotence. Okay, so these are some of the hormones in the anterior pituitary, so that can, when it increases and decreases, the disorders that can arise. Okay, so that have been shown here. So moving to the next one, pituitary hormones. So pituitary hormones, as I had already told you, posterior pituitary hormones, as I had already told you, ADH and oxytocin. So these are the two main pituitary hormones. Okay, so ADH is nothing but anti-diuretic hormone. Okay, anti-diuretic hormone. So through the term itself, you will understand anti-diuretic, which means what? It will prevent too much of removal of fluids from the body. Okay, so it will be preventing the diuresis effect. Okay, in the sense, it will always direct the kidney to restore sufficient amount of water, whatever is required to our body. ADH and kidneys, so they will have to act together. Okay, for the normal for the normal functioning. Okay, yeah. So now ADH, if it increases, it will be causing SIADH. Like, so too much of controlling the kidneys, what the kidneys will do, it will retain everything in the body, causing SIADH, which is syndrome of inappropriate anti-diuretic hormone. Whereas decrease, what it will do, it will remove everything from the body. That can lead to diabetes insipidus. Okay, we'll discuss this later. And oxytocin increased effect will be helping in childbirth, in release of excess milk, and decreased effect will prolonging the childbirth. Okay, so decrease the milk production and all. So is that clear? So these are the posterior and the anterior hormones. So how are the hormones that are basically helpful in carrying out most of the body's functions. Okay, so coming to the primary disorder of this pituitary hormones, the primary disorder will be hypothyroidism, hypopituitarism and hyperpituitarism. Okay, so in general, when pituitary goes low and pituitary goes high, what are the basic problems? Okay, So see here, pituitary is mainly responsible for controlling all of our body's function, isn't it? Whereas the increased effect of pituitary is on growth hormones. Okay, so whereas growth hormone is directly, why? Because growth hormone is directly released from the pituitary. It is not directing any such organs as like thyroid or adrenal and all. Okay, so growth is directly influenced in the body. So therefore, hypo and hyper basically have a greater effect in growth related problems. Okay, so now first let us cover about hypopituitarism. So hormones that are basically affected are growth hormones, gonadotropic hormones. Okay, so these are all responsible for the growth. Fine. And also the other hormones that can be, this may not be usually affected, but sometimes it can be. They are TSH, ACTH, ADH, whereas the growth hormone is mainly affected. Okay, yeah. So now what happens? The first thing we are going to discuss is about hypopituitarism. Okay, so any idea what could be the causes for hypopituitarism? Do you have any idea what could be the causes? Yes, why hypopituitarism can arise? What could be the reason? Yes, reasons could be, it could be tumors. Okay, so tumors or any infection of the brain like encephalitis. Okay, so encephalitis, even stroke. Okay, yeah, stroke, meningitis, very good. Or sometimes even autoimmune related problems. So these all can cause hypopituitarism. Mainly tumors or adenoma is one of the main causes we can say, fine, for hypopituitarism. So as I told you, the growth effect, okay, the growth is basically affected here. So therefore, the primary feature will be dwarfism. Dwarfism. Okay, so you need to know dwarfism or short stature. Okay, so that is what you see there. So, and apart from that, the client will be having the other related problems like excessive thirst, urination. Okay, so when the hormone level decreases, anemia, weight loss, these are some primary features that you need to know, mainly dwarfism. Okay, and also the vital functions also will get greatly affected, in the sense the like you need to know, coming to the vital signs, mainly the blood pressure. Any idea? So how does the blood pressure get affected there? So any idea? Yes, when all effect gets totally reduced. Okay, so what about the blood pressure? What about the cardiac output? Any idea? It will be low. Yes, low blood pressure. Okay, so and also low cardiac output. Fine. Okay, and also since this pituitary is, sometimes if there is tumor and all, so the client can usually end up having headache, dizziness, so vision problems and all. Okay, so these are the main features for hypopituitarism. So for hypopituitarism, what can be done? So based on the hormone deficit, the hormone replacement has to be, so we will have to focus on hormone replacement. Okay, but always remember, see, in pituitary disorders, we are basically going to discuss about the disorders in the sense when the hormones are decreased and increased, what will happen. That is the only aspect that we are going to focus in the entire disorders. Okay, always when there is decrease, for example, hypothyroidism or in Addison's disease and all, there is decrease, actually decrease of specific hormones. When there is decrease, we give hormones, we replace the deficit hormones. But always when hormones are replaced, you will have to focus on the excess effect also. Okay, the client should always be monitored for its excess effect. Okay, so remember, so always, like for example, when client is on hypopituitarism and when he is on growth hormone replacement, his growth should be properly monitored. You need to check with, you need to compare with the standard growth charts and all. Okay, so it should be properly monitored. Okay, so that's very important. So the excess The other side also can happen if properly the hormones are the client is not monitored when especially he is on replacement. Okay, so that's, and you need to teach the clients regarding the signs and symptoms associated with its excess effects, okay, or the side effects. Education is very important there. Okay, so client education regarding the signs and symptoms of hypofunction and hyperfunction related to excess or deficit hormone replacement. Okay, yeah, that was about hypopituitarism. So mainly you need to remember dwarfism. Okay, and mainly in children there is dwarfism. Fine, and you can see here like gigantism and all you will be finding in the case of hyperpituitarism. Okay, so hyperpituitarism basically will be causing gigantism. So gigantism, okay, so large stature is usually the characteristic features. Fine, okay. So coming here, now further moving to the hyperpituitarism. So actually, as we already discussed, so this is nothing but the anterior pituitary gland. When the hormone is hypersecreted, so that can lead to hyperpituitarism, and again, tumors can be one of the main causes for the problem. Okay, so tumors are considered as the main causes for this. Now, so when there is hyperpituitarism, what can you do? See, if there is hypopituitarism, you can actually replace it, isn't it? So whereas when there is hyperpituitarism, what can you do there?
And surgery.
Surgery, yes, surgery is the basic thing that you can generally do here, isn't it? So surgery has to be done. But what is I mean, so surgery in the sense like you will be focusing on what kind of surgery? Any idea? What kind of surgery?
Hypophysectomy.
Yes,
Hypophysectomy.
removal of pituitary gland, isn't it? So removal of pituitary gland, even radiation therapy is also helpful. So mainly pituitary gland removal we will be focusing. Okay, so before that, let us focus on the other clinical features associated with this hyperpituitarism. So that is large hands and feet. So mainly jaw related, you will be finding the jaw to be thick, protruding. The client will be having arthritis, joint pain, organomegaly, cardiomegaly. Here everything gets increased BP, increased cardiac output. Okay, you will be finding here, and also like hyperglycemia, increased blood sugar levels. So they are the features present in hyperpituitarism. Okay, yeah. So either you can basically give the drugs to suppress the growth hormone, or else you will have to prepare for radiosurgery, and very importantly, hypophysectomy is the surgery that is opted here. Okay, so hypophysectomy. So hypophysectomy in the sense, the surgery that is done to remove the pituitary gland. Okay, so pituitary gland removal surgery is named as hypophysectomy. Okay, so now why? Because the pituitary's name is hypophysis. It is also called as hypophysis. Okay, so that is why. So the removal is something we can call it as hypophysectomy. Okay, yeah. But after hypophysectomy, so this is how it is done. So basically, since pituitary gland is present in the center, just below the base of the brain, so usually the craniotomy procedures and all are usually not opted here. Rather, so intranasally or through sublabial route, so the pituitary gland is captured and then it is removed. Okay, so that is how it is usually done. We call this as sublabial transsphenoidal pituitary surgery. Sublabial transsphenoidal pituitary surgery. Okay, so whereas after this pituitary surgery, NCLEX focuses on its complications mainly. What are the complications? Main complication is CSF leak, okay, infection. So these are the primary complications, and apart from that, it can also cause hypopituitarism. See here, so CSF leak in the sense, so since the pituitary gland is present in the base of brain, so where again the CSF is circulating, so any damage to the structure can cause leaking of CSF. Okay, So now after surgery, you might find the client having drainage through the ears, through the nose, and the drainage that is clear. Fine. But how do you know whether it is CSF or not? So to know whether,
Ma'am, to
yes,
check glucose, it's
very
called
good. Okay,
halo test.
halo sign. You would have heard in the studied in the neurological system, isn't it? So halo sign or also glucose check. CSF is usually clear in nature. Only if it is mixed with blood, it might be a little pinkish. Otherwise, it is usually clear in nature. It is therefore difficult to distinguish between a normal drainage and that of the proper CSF. Okay. So therefore, we check for halo sign. So wherein in a gauze sheet, if you place the discharge, so it will be taking cyclical rings structure. Okay. So that indicates halo sign. So halo sign. Okay. Hope you have learned in the neurological system. Fine. So then apart from that, this CSF consists of glucose as well as proteins. Glucose is present in this CSF. So therefore, if you check the glucose, it will show positive. So that is, whereas the normal drainages, pus and all will not be showing positive for glucose. So that is how you distinguish the CSF from other drainage, right? So chances of infection is very high. You need to protect the client from infection. All the infection control measures have to be carried out. Okay, yeah. So there are other, and also of course, when the gland is removed, sometimes the client can get into hypopituitarism. So in that case, the client will have lifelong replacement. He will have to take lifelong supplements in the sense hormonal replacements. Okay, so that has to be done for him. Okay, yeah, so that also should be monitored. Now, post-operative interventions are very important for NCLEX. You need to monitor for the sodium, potassium chloride. Glucose levels should be monitored. So that is usually normal for every aspects, isn't it? So then bleeding is important because this can actually have, but since the client is having nasal packing, you may not note the bleeding externally. The client will be, because since that is done through sublabial route, he will be having intranasal packing and all. Because of that, the blood cannot be visible externally if there is bleeding. But so therefore, you should monitor the client here. So monitoring in the sense, if you note the client is having, or if you see the client to be swallowing repeatedly, okay, if you find the client to be swallowing, so that could indicate he's actually bleeding internally. So this is a very important indicator of bleeding. Okay, so if you find him always swallowing, so that is nothing but there has been bleeding. So which, because of the dense nasal pack, so it is, the blood is not seen externally, whereas the client is actually swallowing it. That's what it indicates. Okay, so that should be monitored. Whether he is monitoring for bleeding is very important. Apart from that, so his mouth will usually be open and he will be breathing through his nose, and he will experience numbness and also diminished sense of smell. So that will be there for 3 to 4 months after surgery. Even after 2 or 1 month, if the client says that I can't smell properly, you should say that is the normal. So that's absolutely normal. Of course, the smell will improve gradually. So sense of smell will improve gradually. Okay, yeah. And of course, since it is a neuro related surgery, a neurological assessment should be done every hour. So that is the frequency for the first 24 hours, and after that, so then every 4 hours you will have to carry out. Okay, yeah. So these are the important neurological post-operative assessment. Okay, the basic ones. Apart from that, so you can provide the client with antibiotics, analgesics, antipyretics. Okay, so oral mouth rinses can be given. Fine. So glucocorticoids are administered so that, see, usually once the pituitary gland is removed, all of a sudden the hormone levels will get reduced. This should not happen. So therefore, the client will be on glucocorticoids. Fine. Okay. And all the ICP related interventions, intracranial pressure related interventions like avoiding straining. Okay, so what all can you name a few measures to prevent ICP, increased ICP? Can you name a few? What should be the positioning? Yes, for elevated position, isn't it? Okay, so then what else? What else you should monitor in the client? In the client, what you will be monitoring for? Yes,
Analysis.
Avoid nausea and vomiting.
loss of consciousness. Yes. Okay, very good. So
Dizziness.
that should be monitored. Yes, dizziness. No, like I mean, so the client should be prevented from all straining aspects like bending, coughing, blowing. If a ICP increases, so there will be vomiting, projectile vomiting. You will see. Okay, so they are the indications of increased ICP. So level of consciousness changing and all our vomiting, projectile vomiting and all our indications of increased ICP. You should be monitoring for these aspects regularly. Okay, so that's very, after any neuro-related intervention, you should be monitoring for the raised intracranial pressure. Okay, and also should apply the interventions that will help in preventing the raised intracranial pressure. Okay, yeah. Toothbrush is usually avoided, so because that can cause a rupture of the sutures. Okay, yeah, and as we already discussed, so the CSF monitoring is very, very, very important. Okay, yeah. So these are the main aspects after hypophysectomy, so that you need to know. Is that clear? It's very important for NCLEX. In pituitary disorders, hypopituitarism, hyperpituitarism, you have understood the difference. For hypo, we give hormone replacements. For hyper, radiation, surgeries, mainly hypophysectomy, care after hypophysectomy is very important for NCLEX. Okay, so based on that, you can expect questions. Okay, yeah, I believe that was clear. That was in general. Yeah.
Hello. About the you mentioned to them about the type of surgeries that are being done. You said the hypophyxectomy and then the sublibrar transphenoidal.
Yeah.
Are they done in two different points?
Yes.
Or are they all done?
Yeah, sublabial. So the sublabial is usually done so underneath the sublabial transphenoidal, in the sense, so where the inside the mouth, you know, so the mucosa,
the upper gum, right?
Yeah, exactly. Okay. So that is inserted there, like I mean, so through that way the approach is taken. Okay, sublabial approach, in the sense through the nasal cavity, through the mucosa. Yeah.
Okay, so through this part, that's why the toothbrush is not, because it's already in the gum, so you can't use toothbrush to brush your teeth, right?
No, yes, but the suture, because of the toothbrushes.
Yeah,
so,
yeah. I want to just get clarified.
Yeah. Okay.
Okay. Thank you.
Okay. Fine. Okay. Okay. So sublabial. So that was because, so through the nasal approach, when it is taken, you know, sutures are there. So when you use toothbrushes, that will easily rupture. Okay. So that's why. Fine. Okay. So any doubts? Anything else apart from this? So these are the main points, so that are mainly highlighted. I want to bring your focus here. Okay, so very, very important. Fine. Moving to the next condition on posterior pituitary disorders, diabetes insipidus is the first thing that we are going to discuss. Okay, diabetes insipidus, in the sense there is decrease of ADH. ADH is posterior pituitary hormone, and that's released by posterior pituitary gland. This ADH, as I already told you, it has got an control over kidneys. Okay, now ADH, when it decreases, so again, may I know what could be the causes for ADH decrease? ADH decrease, any tumors, isn't it? Yeah. Yeah, exactly. So ADH can decrease because of any adenomas, tumors and all. So mainly, okay. And also see here, ADH can also decrease because of several other causes too that you need to know. So ADH decrease can happen even because of neurogenic causes. Okay, so we can say that diabetes insipidus could be mainly due to neurogenic, okay, so nephrogenic, and also some drug related causes. Okay, so drug related causes. So do you know what are those? So basically, can you say how it is related? Yes, neurogenic, drug, nephrogenic, and drug related. So neurogenic in the sense,
Neurogenic is maybe when there is head injury, it can be affected. Yeah, it
e-
can affect the ADH,
ex-
ADH, yeah.
exactly.
And when
Okay.
there is head surgery, yeah, any surgery in the head can affect it.
Yes, exactly. Okay. So neurogenic in the sense mainly when that could be related to cranial problems, or it could be because of the damage to the pituitary gland from trauma, radiation, or surgery. Okay. Then what about nephrogenic? Nephrogenic occurs. See, I told you ADH should be acting on the see, the kidneys should receive the signals from the ADH. Okay, but nephrogenic in the sense when the kidneys tubules, okay, do not react to ADH. It can be inherited also. When kidneys don't react to ADH, that could be nephrogenic cause. Okay. Then drug induced. Drug induced in the sense lithium, mainly you need to know. So lithium demaclocycline. Okay. So these drugs. So these drugs are basically responsible for bringing changes in the level of the way the kidneys respond to ADH. Okay, so the drug induced demaclocycline or declomycin, we usually say. Okay, declomycin or demaclocycline. Okay, so have you heard about other uses of this demaclocycline? So where it is used, any idea? Demaclocycline, a kind of antibiotic it is. It is also used for SIADH. Okay, we'll discuss about that. Okay, so this will especially when clients are retaining too much of water in the body, you know. So this this drug is actually useful. Okay, so demaclocycline. So just note the point, and it's mainly used in SIADH. Okay, syndrome of inappropriate anti-diuretic hormone treatment. Yeah. So lithium is a mood stabilizer. Of course, you know that, isn't it? Okay. So coming to the further points on diabetes insipidus. What are the clinical features? See, the ADH is actually reduced there. So therefore, the kidneys are not, or they are not reabsorbing. The resorption is totally reduced by the kidney. So that will end up in excreting large amounts of dilute urine. Okay, so large amounts of dilute urine. So this can lower the urine specific gravity, large amounts of dilute urine. So what do you understand by urine specific gravity? In the sense, the amount of electrolytes and all in the urine is totally decreased because of large amounts of dilute urine. Low specific gravity, remember this. Okay, polydipsia, the client is more thirsty to drink water. Dehydration, fatigue, headache. Okay, and because of loss of water, this point is very important. The client can have postural hypotension, and therefore safety related interventions you will have to focus here. Fine. So vascular collapse, hypovolemia, and all can generally occur here. So therefore, the client will have to be monitored for postural hypotension. Very important point, because the water, the amount of water in the body is decreasing, isn't it? So it is decreasing. So there is polyuria, polydipsia. Okay, the client is having dehydration, and that could be evidenced by too much of thirst, muscle weakness, headache, constipation, and all, because the water level in the body is getting decreased, sunken eyes, and all you generally see. Okay, so now therefore the clients mainly you should be monitoring for all these aspects. Okay, so the posterior hypotension, and monitor for the electrolyte levels. So when our body has usually no water or in dehydration, what happens to the electrolytes? Will it increase or decrease? Will it
Increase.
increase? Yes.
Decrease.
Electrolytes
Decrease.
Increase.
Increase.
in dehydration, the electrolytes
Increase.
increase. Yeah, it is increasing. Okay, so in dehydration, the electrolyte increases, mainly potassium and sodium will increase. Okay, increase in potassium, sodium. You also learned in diabetes mellitus, isn't it? So DKA, what did you learn there? So when blood sugar levels are very high, the body is ending up in dehydration, causing increased potassium. Didn't we learn that? So dehydration will increase the electrolyte levels, and therefore serum osmolarity is increasing. Okay, so serum osmolarity will be increased. Increases the amount of electrolytes present in the serum is increasing. Dehydration will increase the serum osmolarity, whereas urine specific gravity gets decreased because there are no electrolytes in the urine. Okay, all electrolytes are retained in the body, causing low specific gravity of the urine, whereas serum osmolarity will be increasing. Okay, so therefore, so you should be monitoring for the electrolyte value, all the electrolyte values. Okay, yeah, and of course you need to check the weight of the client. Avoid foods or liquids that produces diuresis, and for this we can give the hormone vasopressin itself. It is basically in what form it is mainly available? Vasopressin, yes, which is easily
Injection.
injection, spray. Okay, desmopressin spray is also there, nasal spray. So in that ways also the client can usually self-administer. Fine. Okay, so that was about the interventions that you need to focus. Okay, yeah, so these are some important aspects in regard to the diabetes insipidus. Okay, whereas there are some other points also you need to focus here. I mentioned about administering IV hypotonic saline because our body's fluid is getting eliminated. In that case, you will have to administer fluid which is hypotonic, which means that the fluid that has got low electrolytes, whereas too much of water content in it. So that should be administered to maintain the body's the replacement. Okay, so therefore when hypotonic solutions are administered, you will have to watch for the signs of water intoxication. Okay, so water intoxication, so that is very, very, very important. Okay, water intoxication in the sense the client can so what do you understand by water intoxication? Any idea? So when excess of fluids are administered, the client would be ending up having edema. Yes, edema and yeah, interstitial. Yes, sodium. What did you say about sodium? Sodium level will
Increase.
In water intoxication,
Decrease.
sodium
Will
level
decrease.
will decrease. Yeah,
Dilutional
It will dilute every of the
Dilution.
electrolytes.
it dilutes the electrolytes. Very good. Okay, so in dehydration, the sodium will increase. In dehydration, the sodium will increase. Whereas when you give water, when water become excess, when it gets large interstitial spaces, so that is called as water intoxication. And in that case, the sodium gets diluted, causing hyponatremia. In water intoxication, the sodium is less. Okay, don't get confused. You need to watch for these signs only when hypotonic administration is there. Okay, so that is very important. Fine. So then apart from that, monitoring mouth care and all soft toothbrushes. So these are the other ways. And also ADH replacements, replacement drugs, vasopressin, Carbamazepine, so remember this, carbamazepine is also given, so which is an anticonvulsant, but at the same time, it will help in releasing the ADH, okay? So that's why. So, and also constipation also you should monitor, fine? So that's very important, okay? So these are the aspects under the, this one, diabetes insipidus. Is that clear? Yeah. So we'll move to the
Ma'am,
next.
sorry.
Yeah.
Ma'am, what about the blood sugar level in this?
So blood sugar level can go high, okay, but no direct much effect there. So blood sugar level can go high because the electrolytes, everything gets increases, and therefore, so sometimes it can go high, okay, yeah, but not too much of effect. We don't see greater effect on the blood sugar levels here, okay.
Okay.
Yeah. So is that clear? So that was about the diabetes insipidus. Okay, so you should be monitoring for these aspects. So all the tachycardia, polydipsia, dehydration should be monitored specifically. Okay, yeah. So let us move to the next one, SIADH. SIADH is the opposite of diabetes insipidus. Okay, so SIADH. So where the action of ADH is more. So when action of ADH is more, the kidney is trying to retain more and more of water in the body. Okay, so the kidneys retain water and therefore the urine output decreases. But the sodium gets excreted from the body, it gets diluted and the sodium gets excreted from the body, leading to hyponatremia. Okay, so hyponatremia. So here you need to know that too much of increased intravascular volume can cause water intoxication and hyponatremia. Okay, so now when too much of water is lodged in the body, the brain pulls it, causing cerebral edema. Okay, so you should be monitoring for these changes in the level of consciousness and all should be monitored here. Okay, yeah. So very importantly, so let me say, like what you should focus here is you need to first check for the early symptoms of SIADH. So that is headache, because the water amount is, the fluids are more in the body, isn't it? So it is increasing the blood pressure, causing headache, weakness, anorexia. So these are common. Whereas as the sodium decreases, the client's brain starts showing, so the brain gets irritated, causing personality changes, hostility, sluggish, deep tendon reflexes. So decreased sodium will decrease the deep tendon reflexes. Okay, nausea, vomiting, diarrhea, oliguria. So these are the other manifestations that you should be focusing on. Okay, something related to the sodium is very important based on sodium. Apart from this, you can also think the other aspects. What all will happen? See, when water is retained too much in the body, monitor for these aspects. Okay, so that could be the heart will start beating more, tachycardia, hypertension, crackles in the lung because of excess water retention, crackles in the lungs if there is congestion. Okay, so that can be evidence as crackles. Distended neck veins, the manifestation of increased water in the body. Distended neck veins, because the heart, the right side of the heart, the superior and inferior vena cava is trying to bring too much of fluid to the right side of the heart, and that therefore at the central line, so the neck veins will be distended. So all the aspects of signs of fluid excess you need to know here. Taut skin, shiny skin, okay, so edematous skin. So these are the aspects that you can, the features that you can see in SIADH. Fine. Here also safety is important here. So of course, when too much of a fluid volume increases, confusion, lethargy and all can generally happen here. So safety is very important. Seizure precautions should to be maintained. Okay, and you need to monitor for the signs of increased ICP. So because of cerebral edema, the water gets pulled in. Okay, So I hope you are relating everything. The water gets cerebral edema, seizure precautions, all the precautions to promote the venous return. That is, so elevation of the head of the bed. Okay, so and to help in the so that the like I mean, so the when this head of the bed and all gets elevated, you know, so what will happen? The increased ICP gets decreased. Okay, so that is the basic reason. So why we focus in that way, fine. So all these aspects are very important here. Okay, yeah. So moving further, you need to restrict fluid intake. Okay, restricting fluid intake, hope you know that. Diuretics can be provided. Okay, so and but the serum sodium level should be monitored. It should be near to normal. So then only diuretics can be provided, whereas further loop diuretics will be causing hyponatremia. So therefore, diuretics, loop diuretics, thiazide diuretics will be causing hyponatremia. While the client is on diuretics, you should be monitoring for the sodium level. That is important. Okay, yeah. And even potassium gets removed with loop diuretics like furosemide and all, potassium gets removed. So you should be monitoring for that. Okay. So then these are the medications, as I already told you. Lithium, they are dimethylcycline, Lasix. But this lithium, when the client is on lithium, you know, so you should monitor for which electrolyte? Importantly,
Sodium.
sodium. Yes, very good. Okay, sodium, potassium. Mainly, if sodium level decreases, the lithium can become toxic. Okay, so these are all related indirectly. Being a nurse, you should be aware of all these aspects. Okay, yeah. So hope you have understood about these aspects. Please focus on these points, so which are very important. Okay, so is that clear? Yeah, dimethylcycline, lithium, Lasix are the drug of choice for SIADH. Any doubts here? It could be a little confusing because both we are discussing here, hypo and hyper. Okay, so you should be understanding the differences properly. You know, if you, I mean, so mainly when it comes to this thing, hypo and hyper, you know, so because when something is hypo, when we give the medicine, you should be, when we treat the clients, you should be focusing on its hyper effects also. Okay, when for hyper, when something is done, you should be focusing on its hypo effects also. So therefore, in all those aspects, if we consider, it can be a little confusing, but still it's easy if you try to relate everything, you know, so it will be easy only. Okay, yeah. So let us, based on this discussion, let me put a few questions to you. Okay. I'll just try to, yeah, hope you can see. Yeah, can I get the answer for this? See, when you don't, like, at least if you are confused, you know, you can think of the other options at least. And then you can determine what can be the answer in that way also. Yes, all have given the right answer. So what's carpal tunnel syndrome? Carpal tunnel syndrome is, I mean, what happens in carpal tunnel syndrome, where the hand and all, you will always experiencing a kind of paresthesias, numbness and all. So that is carpal tunnel syndrome. Okay, so you can think like, So how is the question focuses on the nurse case for a group of clients on MedSurg floor. The client with which condition is at highest risk of developing SIADH. SIADH is related to hormones, isn't it? So retaining hormones in excess. How can carpal tunnel syndrome be related? That is nothing but a nerve problem that occurs in the wrist, in the median nerve and all, that will get pinched, and because of that the client will be experiencing a kind of numbness, tingling sensation and all. So that is in the carpal tunnel. It is not related to the any hormone as such. And diabetes mellitus, can you think of diabetes mellitus?
No.
Of course, no, isn't it? So diabetes mellitus, again, where there is hyperglycemia, it is related to insulin problems and not SIADH. What is sciatica again? Sciatica, that is also related to the nerve problems, isn't it? Sciatic nerve. And of course, fourth one is the right answer here. See here, what happens is, here you need to understand that. So in small cell lung cancer, okay, or what happens is that this is something, the cancer cells, okay. So these cancer cells have got the ability to produce certain hormones. ADH and all can get produced through the cancer cells, okay. So especially when they are having lung cancer, small cell lung cancer and all, you know, so they secrete ADH, and this secretion can lead to SIADH, okay, the problem. And therefore fourth one is the right answer. Malignancies, okay, any drugs, mainly drugs like desmopressin, too much for diabetes insipidus. If the client is taking too much of desmopressin, carbamazepine and all, then that can cause SIADH, okay. So, and usually a small cell lung cancer can be considered as one of the causes for SIADH, and therefore option 4 is the right answer. Moving to the next one. I want all of you to try and give me the answers for the next one. I expect your answers in the chat box. Go with the Q words, okay? Which data should the nurse expect with the onset of this condition? What she should expect? For SIADH, think when water is retained more in the body. So will there be decreased serum osmolarity or increased?
Decreased.
Serum osmolarity. See, the client is having SIADH, isn't it? So water is more in the body. Will the electrolytes be more or will it get diluted? In dehydration, what did I say? In diabetes insipidus, when the body gets removed or when the body becomes dehydrated, the electrolyte becomes more in the blood, isn't it? So that will be causing what? That will be causing increased osmolarity. That will be, I mean, so here, what happens here? The osmolarity decreases, okay? So in SIADH, the osmolarity decreases, okay? So therefore option 1 is one of the answers. What about the specific gravity? Specific gravity increases. Yes, increases. See, don't get confused with osmolarity and specific gravity. In easier way, I can tell you, serum is blood, isn't it? So osmolarity is the amount of electrolytes and the components dissolved in the blood. When water gets removed from the body, all the electrolytes comes out. That will be accumulated in the blood, okay, causing its increase. So therefore in dehydration, so the osmolarity increases, okay, the blood osmolarity increases, whereas the electrolytes are, since it is there in the body, it will not be there in the urine. So therefore in dehydration, the osmolarity decreases in urine. No, sorry, in the specific gravity in urine gets decreases, okay, it gets decreased. Whereas in body, the serum osmolarity increases the specific gravity of urine gets decreased when in dehydration. Okay, so whereas when water is retained in the body in CCF or in SIADH conditions and all, so what is happening? The water content is more in the body. Water intoxication is there. So the electrolytes gets diluted, okay, and the electrolytes gets decreased there, causing decreased serum osmolarity. Whereas, so in the urine, the specific gravity and all can be more, okay. So therefore, so high, they are opposite, fine. So in SIADH, decreased serum osmolarity, whereas high urine specific gravity you need to know. Whereas in diabetes insipidus, increased osmolarity and decreased specific gravity. Okay, yeah. So will there be increased output? No, isn't it? So whereas low serum sodium. So therefore, 1, 3, and 5 are the right answers. Okay, moving to the next one. A client admitted to the ICU with the diagnosis of brain tumor complicated by transient diabetes mellitus, insipidus. Which client data related to the complication should the nurse expect? Which means what are the symptoms, signs and symptoms associated with diabetes insipidus? How is the urine? Will it be dark in color with sediment?
No, it will be clear.
It will be, yeah, diluted urine, right? What about the serum osmolality?
High.
High, okay. What about the specific gravity?
Low.
Low. So what about the weight gain?
No.
No weight gain. What about thirst?
Yes.
Yes.
Okay. So therefore, so 2, 3, and 5 are the right answers. Okay. Hope you are clear with that. Yeah. Moving to the next one. The nurse cares for a client admitted to the hospital due to confusion. The client has non-metastatic lung mass and a diagnosis of SIADH. Which action should the nurse expect to implement? For SIADH, can you implement fluid bolus again?
No.
No, very good. Fluid restriction?
Yes.
Yes.
Do you have to restrict salt?
No.
No.
No. So already hyponatremia. Seizure precautions?
Yes.
Yes. Strict record of fluid intake and output?
Yes.
Yes. Very good. Okay. Yeah. So moving to the next one. Yeah, next one is related to the other topic. Okay. Yeah. So we'll move to the next condition for discussion. I hope you are clear with the topics that we were discussing as of now. Okay. Yeah. So moving to the next topic, we are going to focus on disorders of thyroid gland. So what is the function, the main function of thyroid gland? Any idea? Main function of thyroid?
Metabolism.
Metabolism. Very good. Metabolism. Okay. So the hormones that are secreted by the thyroid are T3, T4, and these hormones are actually stimulated by TSH, isn't it? So these are the normal values. So and the main function of thyroid gland is to increase metabolism. Apart from that, the thyroid also produces calcitonin. Okay, so this calcitonin is responsible to lower the serum calcium. So, and there is also behind the thyroid gland, so there are tiny 4 glands located, and that is what we call it as parathyroid gland. Okay, so behind the thyroid gland, so there are 4 glands, tiny glands located. If this is the thyroid gland, behind there are 4 tiny glands located, and they are called as parathyroid glands. Okay, so these parathyroid glands, what do? The main function is to produce calcium, or it is basically responsible for producing the calcium in the blood. The calcium level keeps increased if increased parathyroid hormones are there. Okay, but too much of increase in blood calcium will be decreased by calcitonin. Calcitonin is needed, that is produced by the thyroid gland, So which will help in regulating, in decreasing the calcium level of the body. Okay, so calcitonin will help in strengthening the bones also. Calcitonin, okay, so it is made up by the thyroid hormone. So whereas the calcium, since parathyroid keeps producing calcium, calcitonin sees that the calcium is getting regulated properly. Okay, so that is the main function of calcitonin. Fine, so it will decrease the calcium from the body. Okay, it will make sure that in the blood the calcium level do not exceed. So that is what the calcitonin does. Fine, so these are the main hormones produced by the thyroid gland. Fine, okay, so now the disorders here also, you know, hypo and hyperthyroidism, isn't it? So now let us identify, let us go with some of the tests that are usually done to identify the problems. Okay, radioactive iodine uptake test is the one test wherein the iodine absorption, how much, see, what is the significance of iodine? Why iodine is needed to our body? Yes,
It
iodine,
helps in producing. It helps in producing the the T3 and T4.
iodine
Stimulates
helps in, yes, iodine helps in producing the thyroid hormones. Okay, so if iodine is adequately there in our body, so then the thyroid hormones also gets produced properly. Okay, so if there is any decrease in iodine, so then we find problems in decreased thyroid hormones. Okay, yeah, so can we produce iodine on our own? Can we produce, will our body produce iodine on its own?
No.
Will our
No.
body produce? No.
No.
Okay, our body cannot produce iodine on its own. Okay, so therefore, so how we get it? How do we get it? How do we get it?
From iodized
salt.
salt.
From food, yes. Okay, so
About salt?
mainly through salt, through iodized salt and all, we get iodine. Okay, so our body cannot produce iodine on its own. Only if iodine is there, the thyroid hormones get produced normally. Okay, yeah, so therefore, but this iodine, like we do basically these tests to check whether the iodine is getting properly taken by the thyroid hormones or not. Okay, so that is one test, what we call it as a radioactive iodine uptake test. Okay, the client has to be on NPO for this test, and then, so what is done, he will be given with the radioactive, yes, Arya, so you have raised your hand. What happened? Any doubt?
Yeah. How does iodine help to produce those hormones? Is it help to
It is,
convert that T3 to T4, or like how does it help it?
yeah, iodine, see, thyroid gland absorbs iodine, and then the iodine gets, after absorbing the iodine, so the brain also will be stimulating it by releasing the TSH. Okay, so through TSH, this gets converted within the thyroid gland to produce hormones. That is how it acts. Okay, the brain's action is also mainly present there. Fine. Okay, so through TSH. Okay, so now this TSH, this iodine has to be absorbed properly. Okay, to check for iodine absorption, we go in for this test called as radioactive test. Fine. So after consuming this, after 2 or 4 hours, it could be taken as an pills, in the form of pills, or also IV. And the absorption is checked by placing gamma cameras. Okay, the percentage of how much absorption has happened will be shown on the screen. Fine. And this iodine, this radioactive sample will be excreted through the urine, and in the urine will be radioactive for 2 days and all. Okay, so that's it. So that's about the radioactive iodine uptake test. Fine. So there is also another test called as thyroid scan. So this is a test where radioactive or technetium scan is or technetium dye is injected into our body. Okay, so that is how it is done. So then after injecting it, So then we the dye insertion, just like any other dye insertion procedure, like CT scan and all, how we do in the same way. So where the abnormalities are there, you know, so those regions are high regions are highlighted, and through the scan we will be able to understand the highlighted sections and all, and through which we can detect the problem. Okay, so what could be the problem that is identified. For this also, the client should be on a NPO, and usually if the client is already on any iodine supplements or medications, like some of the anti-thyroid drugs consist of iodine preparation in it. Okay, so even the client, the physician should be contacted before discontinuing. Usually iodine medications are held for the past 2 weeks before the procedure. Okay, and if the client has undergone any other radioactive procedure in the past 3 months, and also in pregnancy, the thyroid scan is usually contraindicated. Okay, yeah. So coming to the disorders now. So here mainly hypo and hyperthyroidism. So they are the basic disorders. Let us first discuss the signs and symptoms associated with these disorders. This is very important. Okay. Now let me make you you need to think now, you know, the function of thyroid glands, isn't it? So mainly it is responsible for metabolism. So metabolism, when the hormones are less in our body, that is, see this, so this TSH, I did not talk about this TSH. This is very important. TSH is mainly responsible, it is released by the pituitary, and that will help in producing the T3 and T4 in the presence of iodine. Okay, so now when TSH release is more, okay, TSH is more in the sense, what does that indicate? Hypothyroidism. That runs opposite. Okay, hypo, remember, increased TSH levels in the body indicate hypothyroidism, which means that the thyroid glands are not, I mean, so the hormones are less, and therefore the brain is trying to release more and more TSH, okay, so that the thyroid can become normal, but thyroid is still normal. There could be some gross problem. Okay, so increased TSH level indicates hypothyroidism, and decreased TSH level. See here, when there is hyperthyroidism, the pituitary is not releasing. Okay, the pituitary has sensed that there is some problem, and it is controlling its release of thyroid stimulating hormone. Okay, so therefore decreased TSH in the case indicates hyperthyroidism, whereas increased TSH indicates hypothyroidism. Okay, yeah. So moving to the next aspect of this. So now, as I told you, like hypo and hyper, you need to think about the metabolism. Now remember, so when metabolism decreases in the body, what all will happen? See, in hypothyroidism, the metabolism is decreasing. The thyroid hormones are deficit, isn't it? So when metabolism decreases, so suppose when we don't exercise, when we don't run, or when we don't end up in any activities, so when we don't do any activities, our metabolism is decreased, isn't it? So in the sense, like we gain weight, isn't it? So we will not sweat. Okay, so if metabolism is decreased, we are not able to bear cold. We become resistant. So we are so sensitive to cold. Okay, so we are not able to bear cold. Metabolism, when it decreases, our skin becomes dry. Okay, so and all these menstrual problems occur. So you can think in that way. When constipation occurs, because there is no peristalsis. When metabolism is increased, the peristaltic movement is good. Okay, so now when there is no peristalsis, or when there is decreased peristalsis, of course that will end up in constipation, premenstrual syndromes, joint pain, okay, high cholesterol levels. Fine. So because of low metabolism, all these problems will occur. When metabolism is very high, the client can end up having diarrhea because of too much of peristalsis. So then sweating. Okay, So then heart palpitation. So and all these things, weight loss, and all can generally eventually happen. Okay, yeah. So now here there is also a term called as goiter. What do you understand by goiter? Goiter. Any idea? Yes, what is goiter? Goiter is enlargement of the thyroid gland. Why does it enlarge? Why does it enlarge? It enlarges
Due to
usually
excessive stimulation.
to make hormones. Yes. Yes, goiter is a condition that you need to understand where the thyroid gland enlarges. Okay, so this enlarge, see, the thyroid gland is actually very small gland. Okay, so these enlarge is associated with the thyroid hormones, in the sense when thyroid hormones are not appropriate, you know, so then the gland enlarges to make thyroid hormones. Okay, so that is something we can call it as goiter. So goiter can be seen even in hyperthyroidism also. In both it may be seen in certain cases, whereas normally it is seen in hypothyroidism. Okay. Goiter. And have you heard about Graves' disease? Graves' disease, Graves,
Hyperthyroidism.
Hashimoto's.
Is that bulging of eyes due to hyperthyroidism?
Graves, what is due to hyperthyroidism? Graves and this one, Hashimoto's, are both autoimmune disorders. Okay, so Graves' disease will cause hyperthyroidism. Hyperthyroidism. Okay, so Graves' disease, and Hashimoto's usually causes hypothyroidism. Okay, so hypo will be called, that's why I have put it there. So in both sections, Hashimoto's usually causes in Hashimoto's disease, it is a kind of infection of the thyroid gland. You need to know. Okay, we call it as Hashimoto's thyroiditis because some bacteria and all will, it's an autoimmune disorder where the microbes will be invading the thyroid gland and it will be destroying the thyroid gland. Okay, and that's why the thyroid hormones will go low. And Hashimoto's is usually an autoimmune disorder. Okay, and this causes hypothyroidism, and Graves' disease is also autoimmune, causing hyperthyroidism. Okay, yeah. So these are the signs and symptoms that you need to know here. Right. So let us discuss one after the other now. So hypothyroidism is the first topic that we are going to discuss. Okay, so hypo, as you know, T4, T3 both are low and TSH gets elevated here. So primary and secondary hypothyroidism we have. Primary hypothyroidism, we say when the problem is with the thyroid gland itself. Secondary hypothyroidism, we say the problem is with the TSH. Okay, so that is why we call it as secondary, right? Okay, now here for hypo, we will have to, as you know, we have to replace with the hormones, isn't it? Levothyroxine sodium. And the diet you need to know, because the metabolism is less in the body, the diet also should be low calorie, low cholesterol, so that the it is easy for the body to digest. The metabolism is very less, isn't it? So therefore, low saturated fat diet, low cholesterol diet, and all you will have to start the diet with. Okay, and also sedatives and opioid analgesics should be avoided here. Any idea here? Why? Because these sedatives and opioids will be acting on the respiratory system. See, in hypo, yeah, exactly. In hypo, usually everything is in its decreased form. Our body is functioning, everything. There is bradycardia. Okay, so the cardiac output is decreasing, the blood pressure is decreasing, everything is already in its decreased form. On top of that, if you give opioids and sedatives, it will cause gross decrease, precipitating to a complication called as myxedema coma. Do you know what is this myxedema coma? See, myxedema coma is when continuous low thyroids are produced, you know, so then the client can have myxedema coma. So some of the reasons are any illness, sudden illness, okay? So, or suddenly when the thyroid medication is stopped when the client was on thyroid hormones and suddenly stopping the medication, surgeries, hypothermia, or use of sedatives, analgesics. So these can cause mixed edema coma. Remember, so these points are very, very important. Okay, the manifestations are hypotension, bradycardia, hypothermia, everything decreased, respiratory failure, and even coma can occur here. Fine. So therefore, if a mixed edema occurs, then the primary focus should be airway. Okay, aspiration, IV fluids, levothyroxine also IV you have to give, glucose IV, everything decreased, steroids, temperature hourly monitoring, blood pressure monitoring, the client should be kept warm, mental status monitoring. Okay, so these are the interventions you will be focusing in mixed edema. Remember, what is mixed edema? Mixed edema is a complication of hypothyroidism, which can be precipitated by opioids, sedatives, or any sudden stopping of drugs. Okay, so so these are some of the factors. So mixed edema coma. So that's one thing that you need to know, the complication of hypo. Okay, apart from that, see here, when a client is on the thyroid medications and all, in the sense thyroid hormone, you should instruct. This is under the client education. Okay, very importantly, you need to educate about the signs and symptoms of hyperthyroidism. Okay, like if the client experiences chest pain, tachycardia, nervousness, and all, immediately she will have to contact HCP, because they are the indications of overdosage. When long time hormone placements or hormone administration can end up having over hormones also. So they are manifested as tachycardia, chest pain, and if the client reports or experiences these problems, so then she will have to report to her HCP immediately. Okay, so these are the aspects under the hypothyroidism. Okay, so moving to the hyperthyroidism. See, hyperthyroidism in the sense, as you know, like there is release of or surge in the hormone levels in our body. So that is what we call it as hyperthyroidism. Okay, so now suddenly when hormone surges, so that can cause hyperthyroidism. For hyperthyroidism, the client will be on antithyroid drugs, that is there. Okay, but the client can end up having thyrotoxicosis. So any idea what is thyrotoxicosis? The main cause is what we can say, Graves' disease. Graves' disease can be causing this problem. Okay, so do you know what is thyrotoxicosis? High levels of hormones in the body, especially the thyroid hormones in the body. Okay, so that is something we can call it as thyrotoxicosis. Hyperthyroidism is increased level of thyroid hormone. Okay, thyrotoxis is wherein the client will be showing up with gross symptoms associated with the hyperthyroids. Okay, so now here what you are supposed to do, so you will have to provide the client with rest, administer sedatives, cool client environment, high calorie diet. Okay, remember, for hypothyroidism the diet was low calorie, whereas here, since the metabolism is very high, so you should be giving high calorie diet. Okay, yeah, avoid stimulants in the form of opioids, cocaine, and all are there. Okay, so those kind of stimulants should mainly be avoided. Fine. And also the client can be going in for thyroidectomy procedure. Thyroidectomy. Okay, so thyroidectomy, so that is usually done so when it is very high. So when very high. Okay, yeah, so these are the main points that you need to know. As I already told you, is there any difference between thyrotoxicosis and thyroid storm? Thyroid storm, any idea? Yes. See, both are almost similar. Thyrotoxicosis can be basically because of the increased level of hormones. Okay. Thyroid storm, we say, because of thyrotoxicosis, thyroid storm will happen, where even the systems get failed because of thyroid storm. Okay, so severe form of thyrotoxicosis is thyroid storm. Okay, uncontrolled hyperthyroidism is thyroid storm, which is a medical emergency. Okay, now here, so there are some causes. These all are NCLEX points. Okay, so especially these one, they come for under the questions. What are the causes? Main cause could be during the thyroidectomy procedure itself, the thyroid hormones can be released. That is one cause. Apart from this, so severe infection, trauma, stress, DKA, and digitalis toxicity. I want you to remember this. Okay, so DKA and digitalis toxicity. So why DKA and digitalis toxicity is related? Any idea? DKA? Yes. So they actually, because of DKA, what happens is when blood sugar levels are very high, the DKA generally, so in DKA, what is happening? So blood sugar levels are very high. Okay, so now when blood sugar levels are very high, the pathophysiology is something very great. Okay, so this blood sugar level, high blood sugar level, will in turn indirectly attack the thyroid. So thyroid glands to to release more hormones. Okay, high blood sugar level. So that is why DKA can be causing hyperthyroidism. So that is one thing. Okay, and also in the same way, digitalis toxicity, when digoxin, when a client is on digoxin, high levels of digoxin will be triggering the thyroid hormones to be released. Okay, even stress, infection also will trigger this problem, and therefore thyroid storm is uncontrolled hyperthyroidism. So that is usually caused by any of these factors. Okay, and you can administer the client with beta blockers, glucocorticoids, iodines, and all. So that is usually done, and usually these medications are also given before surgery, so that during the time of surgery, the thyroid hormones can get released. In order to avoid this, so what is done? So during the before the surgery itself, antithyroid drugs and all are usually given. Okay. Yeah, so these are some of the signs and symptoms: hyperthermia, hypertension. So you can relate all these things. Hyperglycemia. Okay, in hyperthyroidism, hyperglycemia, chest pain, dyspnea, palpitations are the main signs and symptoms associated with the thyroid storm. Okay, thyroid storm. Remember, when suddenly large amounts of thyroid hormones gets released into the bloodstream, where metabolism will become very high. Okay, so if thyroid storm occurs, the client will again should be on airway, cardiac monitoring, and antithyroid drugs are usually given. Okay, beta blockers, glucocorticoids. Glucocorticoids, it will help in preventing shock. IV fluids, insulin is also administered, because if the high blood sugar level is considered as cause, then insulin is administered. Okay, even when thyroid increases, insulin also can get increased. Okay, so therefore all these aspects, and you need to monitor for the clients. Okay, yeah. So coming to thyroidectomy, I told you for hyperthyroidism, the client will be on thyroidectomy. The client can, so the thyroid gland can be removed. Okay, it is removed in many ways, sometimes complete or sometimes partial. It again depends upon the severity of the condition. Okay, so always check for hyperglycemia, because as I told you, hyperglycemia can trigger thyroid storm. So therefore, this should be assessed properly. Remember this point, it's very important. Okay, and administer antithyroid medications to prevent thyroid storm. After the surgery, see, thyroid gland is present in the region where even the laryngeal nerve passes. Laryngeal nerve is responsible for what? for sound production and all, isn't it? So larynx, the nerve that is originating from the larynx. Larynx is the voice box. Okay. Now laryngeal nerve damage can happen here because of during the process of thyroidectomy. And if laryngeal nerve damage has occurred, so the client will experience hoarseness in the voice or stridor. Stridor is a rough kind of sound, like usually in upper airway obstruction, you would have heard that. Stridor, a like a crowing sound. Okay, hoarseness and all indicates that has been laryngeal nerve damage. The client should be in raised head position or semi-Fowler's position. Okay, edema and all those things have to be monitored. And of course, so here, let me add on one more point here, so which is very important. Now, along with this, I would like to talk about the parathyroid disorders also. Okay, so why? Because like see here, so during the process of thyroidectomy, okay, you need to understand. So during thyroidectomy, so what can happen? So even the parathyroid glands can be removed, because so we have learned that these parathyroid glands are the tiny glands that are located behind this one thyroid glands, isn't it? So during the process of surgery, so this parathyroid glands also can get removed. Okay. So therefore, if parathyroid glands get removed, what will happen? The client can end up in hypocalcemia. Okay, yeah, tetany, hypocalcemia. So these are the parathyroid glands that you should know. Okay, so these parathyroid glands, when it's removed, so that can end up in hypoglycemia. So therefore, parathyroid glands, usually if it is removed, you know, so what is generally done is that is implanted into the skin and all, okay, underneath the skin, especially in kidney patients, those who are having kidney disorders. So usually for them, they will be more at risk of developing hypocalcemia. In that case, so parathyroid glands, if they are removed during the process of thyroidectomy, they will be re-implanted with the glands, but not in the same path, somewhere else in the body, usually in the forearm, under the skin and all. So it will be re-implanted, and then its action will be carried out by its own. Okay, yeah, so that is there. So now so therefore you should be, so if during thyroidectomy, if parathyroid is removed, the client can end up having hypocalcemia, isn't it? So so you should be monitoring for the signs and symptoms of hypocalcemia. What are those? Mainly shostak signs, Trousseau sign. We have discussed this a couple of times earlier. Shows the cheek on the same side if there is twitching. Okay, so twitching on the same side causes Shostak sign, and when you tie a BP cuff and when you inflate, if there is a spasm, so that will be causing Trousseau sign. Okay, so these indicate what? Hypocalcemia. So after thyroidectomy, you should be monitoring for hypocalcemia. Why? Because because of the removal of parathyroid glands. Okay, sometimes the parathyroid gets affected. So therefore, so that's very, very important. Is that clear? So how you monitor? So did you understand? Okay, yeah, I believe you have understood. Any doubts here so far? Any doubts so far? Yes, you can ask. I do understand all of a sudden when we focus on so many topics, it could be confusing here and there, but I just want you to be very clear with what we are discussing. Any doubts?
Excuse me, ma'am.
Why? Yeah.
Parathyroid hormone, you said it gets implanted in forearm or somewhere. Could you please explain that?
Yeah, see, that is because, yeah, as I told you, these parathyroid glands are very much needed, isn't it? So because this parathyroid glands will help in calcium reabsorption, okay, and also it will help in removal of the body. I mean, so the excess, this if it is there, you know, so it will help in removal of that excess phosphorus and all, it will help in removal of that. Okay, but sometimes what happens, so we may, during the process of thyroid gland surgery itself, the parathyroid will have to be removed. Okay, so in that case, so what we do, like I mean, so but this calcium is very important to our body. Okay, so if the parathyroid gland is removed, so then the calcium regulation may not happen. So in that case, what do they do is there will be like after parathyroidectomy, the parathyroid tissues will be transplanted either in the forearm. Okay, so means in the forearm, just in the forearm, it will be directly be transplanted, or what they will be doing is even not only in the forearm, sometimes and in the sternocleidomastoid muscle. So we are having sternocleidomastoid muscle near the neck, isn't it? So that is one of the accessory muscles. So in the sternocleidomastoid muscles, so it will be inserted so that the secretion will remain continuing. So that is what is done. Okay, yeah. Auto transplantation procedure we say for auto transplantation of parathyroidectomy. So that is what we say. Okay,
Okay.
understood.
Okay.
Yeah,
Thank you.
fine. So yeah, moving to now, let me also finish the parathyroid and then I'll give you a small break. Okay, because parathyroid, I don't want to talk too much about it and make you confused there. As I already told you, see, parathyroid is needed for increased calcium. I mean, so when parathyroid is it's a normal function, it will help in producing the calcium. Okay, the calcium will be reabsorbed in the body. But when hyperparathyroidism occurs, more and more calcium gets reabsorbed in the body. Then the client will be having hypercalcemia. Okay, and there will be increased removal of phosphorus. Okay, hypercalcemia and low phosphorus level, hypophosphatemia. Whereas in hypoparathyroidism, hypocalcemia and hyperphosphatemia. Remember that. Okay, so now if hypercalcemia is there, so what is usually done? So if the calcium levels are more in the body, so what do you do? Tell me. So what can you do to regulate it? You will have to remove the calcium from the body, isn't it? If calcium level are more in the body, that should be removed. For that, what is done? Any idea? Yes, what is done?
Some
Avoid
surgery.
Yes, if our calcium levels are, if calcium levels are more, so these are some interventions. You can give furosemide, okay, so that the calcium gets removed from the body, okay, and also phosphates are given so that when phosphates are there in the body, the calcium reabsorption doesn't happen. So that is another thing that can be done. Okay, and also calcitonin can be administered. Calcitonin. So calcitonin, it acts opposite to parathyroid hormone, isn't it? So it will make sure to remove the excess calcium from the body. Okay, so that is one thing that you need to know. And also parathyroidectomy can be we can think of parathyroidectomy when in the case of hyperparathyroidism. Okay, in the case of hypoparathyroidism, the client will experience signs and symptoms of tetanus and all. So when see, remember these signs, they are arrhythmias, okay, so tetany and also seizure. Remember cats. Okay, so convulsions, arrhythmias, tetany and seizures, low calcium levels. So therefore, so you should be monitoring for these aspects, very importantly for low calcium levels. And calcium can be administered in the form of like calcium supplements, calcium gluconate. Okay, so remember this, calcium gluconate, calcium supplements and all are actually administered. Vitamin D is administered. Okay, so that is I mean, so the main aspects that you need to focus. Okay, seizure precautions, of course. So low calcium level can cause seizures, therefore seizure precautions have to be taken. So these are the important points. Okay, yeah, so was that clear? So any doubts? So far we discussed diabetes insipidus, the SIADH, hyperparathyroidism, and also pituitarism, hypo and hyper. So any doubts so far? Were the concepts clear? Yes? Yes or no? Why are you
Yes,
silent?
ma'am.
Yes?
ma'am.
Okay. Yeah, okay. Then you can go for a short break now, 5 minutes, and after that, we will be continuing with the adrenal gland disorders. Okay? Yeah. Okay, guys. So welcome back. Let us continue with the remaining aspects. So we will do the questions now. So here is the first question. Okay. The next question. Can I get the answers? Hope you are back from break or are you still on break. Okay, can I get the answers?
Bradycardia, cold intolerance, constipation, hair loss, and
What else?
1, 2, 3, 4. And
What about the skin? Is it warm or dry?
it's dry skin for
Dry.
Yeah,
Yeah.
okay.
Dry skin.
Dry skin. So 5, 6, and 7 you can eliminate, isn't it? So
Yes.
1, 2, 3, 4 are the right answers. Very good. Yeah, 1, 2, 3, 4. Okay. The nurse assesses a client with hyperparathyroidism who had a parathyroidectomy 4 hours ago. Which assessment technique should the nurse use to check for complication in this client? See, hyperparathyroidism. Okay, parathyroidectomy 4 hours ago. So after that, what could be the complication based on what we discussed? So ask client to place back of hands like this. Okay, so back of hands against each other to provide hyperflexion of the wrist while the elbows remain flexed. Okay, so what is this? Like you keep like this to provide hyperflexion of the wrist. Okay, so whereas the elbows remain fixed, what test this could be? Have you heard of this before?
Ma'am, for
It's
carpal
done in
syndrome.
carpal tunnel syndrome.
Carpal tunnel
tunnel
syndrome. Yeah, to check for carpal tunnel syndrome. So you would be doing that test, isn't it? And what is that test called as? Any idea? So that is Fallon's maneuver. P-H-A-L-E-N-S. Fallon's maneuver. Okay, P-H-A-L-E-N-S. Fallon's maneuver we say. Fine. So that is not for the complication of this, isn't it? So therefore you can easily eliminate. Okay. Instruct client to lie down and run the heel of one foot down the shin of the other leg. So when do we ask the client to do like this?
I think it's in meningitis. That's
Yes,
what
to check for the neurological. Yes, exactly. Okay, for meningitis. Yes, okay. So we do that to know whether the client's, so whether the cerebral irritation is present or not. Okay, so that is why we do that. The heel to shin test, we say. Heel to shin test, okay, to check for the cerebellum function, we generally do that. Okay, so what about the third one? That's also Romberg's test. Okay, Romberg's test in the sense, it's also a test that is usually done to assess for the gait and balance. Okay, yeah. So therefore, not Whereas fourth one is the right answer. Of course, you know that why? Because so this is a test that will check for hypocalcemia, and that could be one of the complication of parathyroidectomy, and thus fourth one is the answer. Okay, fourth is the right answer. Yeah, so this is okay. Now we'll move to the next one. The nurse practicing in an outpatient clinic cares for a client recently diagnosed with hyperthyroidism. Which diet-related teaching should the nurse add to the client's plan of care? Emphasize the importance of low carbohydrate diet, or encourage the client to increase high fiber foods in the diet, include meals, snacks high in protein content, teach avoidance of caffeine containing liquids, teach the client about consumption of high calorie of 4,000 to 5,000 calories per day. SATA.
4 and 5. 4 and
3.
Anything else? So what's the question? For recently diagnosed hyperthyroidism. For hyperthyroidism, can you give
2,
low carbohydrate
3,
diet?
and 5.
No.
Calorie.
High protein? Yes. Okay. The client needs high protein, not high fiber, because already there is increased peristalsis, isn't it?
Yeah.
Diarrhea could be there. So therefore, not high protein, so high fiber, rather high protein, yes. Okay, so avoiding caffeine, yes. Okay, so that's also when the stimulants. So we started, isn't it? Stimulants should be avoided. So amphetamines, caffeines, coffee, tea, soft drinks, all sort of stimulants should be avoided, and therefore yes. So that has to be selected. Okay, so what about and also you need to understand if there are any option that said instead of high fiber, even spicy foods, even that should be avoided, because spicy foods will be, you need to think that it will encourage GI motility, isn't it? So therefore even that should be avoided. Okay, teach client about consumption of high calorie diet, yes. Okay,
Yes.
so therefore, so 3, 4 and 5 are the right answers. Fine. Yeah. So now the nurse is completing an assessment on a client who is being admitted for a diagnostic workup for primary hyperparathyroidism. Which client complaint would be characteristic of this disorder? Diarrhea, polyuria, polyphagia, weight gain.
Diarrhea.
Why so? See, when calcium is more in the body, what
Four.
will happen? Yes?
4.
And calcium is
Constipation.
more, constipation. Is there anything else? For
Oh.
hyperparathyroidism,
It's the weight loss, not
Weight
weight gain.
loss, constipation.
weight loss,
Oh.
constipation. Yes. So what's the answer?
Polyphagia.
Polyuria.
Polyuria, yes, okay, polyuria, because increased level of calcium will be reabsorbed more by the kidneys. The kidneys will be trying to filter more, removing the excess water from the body. Okay, so that is why polyuria, very good. Okay, polyuria is the right answer. A nurse is caring for a post-op parathyroidectomy client, which client complaint would indicate that a serious life-threatening complication may be developing, requiring immediate notification of the physician. You need to think of what could be the life-threatening complication
Ma'am,
after
first one, laryngeal stridor.
So nice.
Number
Very
one.
easy. Yes, isn't it? So laryngeal stridor. Very quick answer. Very good. And that was easy too. So very good. Okay. Yeah. Now these
Ma'am,
were
can you show the previous answer, please? The previous
which
one.
previous one. Okay. This one.
No, this one. Yeah.
Yeah.
Okay,
So-
thank you.
Okay. Okay, guys, so that was about hypo and hyperparathyroidism and thyroidism. See, under thyroid, you need to remember euthyroid is normal. Decrease will cause hypo, increase will cause hyper, but too much decrease will end up causing myxedema coma, whereas too much increase will be causing thyrotoxicosis. Okay, so that is what you should remember. Fine. Okay, well, and also the precipitating factors of thyroid storm, thyrotoxicosis, don't forget. Okay, exophthalmos. So exophthalmos is the classic feature of thyrotoxicosis. Okay, yeah, so please don't forget the manifestations. Okay, moving to the next one, we are going to discuss about adrenal gland disorders. Adrenal gland, right? See, as you can see in the picture, the adrenal glands are secreted on top of, they are present on top of kidney, and it consists of two parts, that is adrenal medulla and adrenal cortex. Okay, so this is the cortex and this is the medulla. Okay, now this cortex will secrete mainly corticosteroids. Okay, corticosteroids and glucocorticoids and glucocorticoids. Okay, so whereas medulla will be secreting what? Any idea? So it will be basically responsible for producing aldosterone. Okay, so medulla is basically responsible for that. Okay, medulla is not aldosterone, adrenaline. I'm sorry, just I'll just write it once again. So adrenal cortex and adrenal cortex is basically responsible for mineralo and gluco. Okay, mineralo and glucocorticoids. This mineralocorticoids will be secreting aldosterone. I just got confused. Aldosterone. Okay, and whereas the medulla will be secreting adrenaline and noradrenaline. Adrenaline and noradrenaline. Okay, so these are the hormones that are secreted by the endocrine glands, adrenal glands. Okay, so now here these glucocorticoids and glucocorticoid is responsible for raising the glucose level. You know that. So and mineralocorticoids, what does it do? It will regulate the fluid and electrolyte balance. Mainly the aldosterone released from the mineralocorticoids has got a major role. I have discussed this earlier also. Aldosterone, what does it do? It will retain water and sodium. It will retain water and sodium. Okay, whereas it will excrete what? Any idea? It will excrete
Potassium.
excrete what? Potassium. Very good. It will excrete potassium from the body. Okay, adrenal glands. So these are the hormones that are released by the adrenal glands. Mineralo will be releasing aldosterone. The aldosterone will retain water, sodium, whereas excrete potassium. This is the normal function. Okay, so retain water, and that is why because of aldosterone, the blood pressure is normal in our body. Because water and sodium is retained in our body, the blood pressure is actually regulated by aldosterone. When aldosterone's action becomes more, like in liver diseases and all you have studied, so or in kidney failure and all, the aldosterone's action becomes more. At that time, more and more water gets retained in the body, causing hypertension and all. Okay, yeah. So now, as of now, you remember this. Medulla releases adrenaline and noradrenaline, which are the hormones that help us balance when we are stressed. Okay, or the sympathetic and the parasympathetic nervous system. So you have studied that in the neuro, I believe so, isn't it? So sympathetic, parasympathetic. Sympathetic system is basically adrenaline, noradrenaline, and parasympathetic is the anticholinergic receptors and all. Okay, adrenaline will help in dealing with stress or fight or flight response. Okay, so that is basically helped by the adrenaline, which is in turn helping in pushing the blood pressure and all. Okay, in uptake of or in increasing the blood pressure, adrenaline, noradrenaline. Okay, yeah. Coming to the disorders of this, here we are again going to study decrease and increase of these hormones. That's it. Okay, so now you can see this picture here. Adrenal cortex, as we had already discussed. So because of decrease of mineralo and gluco, there will be Addison's disease. Decrease of mineralo gluco will be causing Addison's disease. An increase of mineralo will be causing hyperaldosteronism. Increase of gluco will be causing Cushing's disease and Cushing's syndrome. Okay, so pheochromocytoma occurs because of the problem in the medulla, in the adrenal medulla. If there is tumor, you know, that is pheochromocytoma. Okay, so remember, Addison's disease is associated with the decrease of the adrenal cortex hormones. That is, decrease in mineralo and gluco will be causing Addison's disease. Increase in gluco only will be causing Cushing's disease. Increase in mineralo will be causing Conn's syndrome. Okay, or hyperaldosteronism we say. Okay, yeah. So now let us look after one after the other. So these, what happens here? As I already told you, there is decrease of the hormones, mineralo, gluco. Now, without even thinking much, you can think of the symptoms here, isn't it? So please focus on, see here, the client will be, everything is decreased. Mineralo, gluco is decreased. So the client will have weight loss because the glucocorticoids is not there. How is the sugar level? It will be decreased. Hypoglycemia. See, aldosterone is decreased, therefore no sodium and water retention, so therefore hyponatremia. Whereas when aldosterone's effect is decreased, the potassium is retained in the body. Aldosterone has to actually remove potassium, isn't it? But potassium retains in the body, causing hyperkalemia and indirectly hypercalcemia. Okay, these electrolyte imbalance, very important. Please remember, just to understand. Addison's in the sense decrease. When mineral glucose decreases, what all will happen? Think in that way. It will be easier for you to know the laboratory changes. Electrolyte changes will be put as the questions. Very, very, very important. Okay. Apart from that, weight loss, see, everything is sodium decreasing, causing hypotension, hypoglycemia, giddiness, it will cause giddiness, and there will be bronze pigmentation on the body. So this is because, see, ACTH is trying to stimulate the adrenal glands. ACTH is the hormone that stimulates the adrenal glands to release these hormones, adrenocorticotropic hormone, whereas that doesn't affect on adrenal, rather, so it will be stimulating MSH, that is melanocyte stimulating hormone. Because of this melanocytes, excess melanocytes that is released, the body will be discolored. Melanocytes are the melanin secreting hormones. Okay, so this melanin will be increased, causing discoloration, bronze discoloration. Okay, you can see here and there, so bronze discoloration in the body. So bronze pigmentation is a feature of Addison's disease. Is that clear? And also you should know the electrolyte values. Fine. So now what are you supposed to do? See, everything is decreased here. So saline infusions, orthostatic vital signs, safety is very important. safe environment. Please focus on these points. Okay, and glucocorticoids, steroids you have to give as IV bolus, steroids administration. Okay, so that's very important, and you should be watching for Addisonian crisis. This is the severity of Addison's disease. Addisonian crisis. I'll come to this. Check for hyperkalemia, hypoglycemia. Steroids are actually given as medications. See, for hyperkalemia, you can give Caixylate, powder form. So it will be there in small packets, and the client can mix it in water and drink so that excess potassium will be reduced. Okay, Caixylate to decrease the potassium level from the body. Is that clear? It's very important. Now, what is Addisonian crisis? Addisonian crisis in the sense, all of a sudden the client was normal till today morning, but after meeting with an accident, so the kidneys were grossly affected, causing abrupt the decrease in the adrenal gland hormones, and that is called as Addisonian crisis. All of a sudden the hormones are getting decreased, and this can end up patient in severe hyponatremia, hypoglycemia, and shock. Okay, so in that case, so what are you supposed to do? So you will have to give IV administration of glucocorticoids, all IV solutions. Okay, so that's very important. On top of that, electrolyte levels. So main 3 points I want to focus here in Addison's disease. One is electrolyte imbalance. Okay, so how are the electrolytes changing? So hope everything is reduced in the body. Okay, so hypoglycemia and hyponatremia, hyperkalemia, hypercalcemia. So that is one thing. The second thing is checking for orthostatic vital signs. Okay, so changes in the vital signs, dizziness and all is a very common problem. Okay, and also so you need to basically the third important point that you need to focus here is like something about the saline infusions. Okay, so the client will be on saline. So these 3 important points: checking for dehydration, and the management is saline infusion. Checking for electrolyte, electrolyte imbalances, that is the second main thing, and third main thing is safety precautions. Okay, so these are very important for Addison's disease. Is that clear? Okay, so what is Addison's disease? Hope you have understood, and also Addisonian crisis, the severity of the disease. Coming to Cushing's disease. See, Cushing's disease can be basically Cushing's disease and also Cushing's syndrome. There is also syndrome. So disease, we say when the problem is with the pituitary. If the pituitary is not stimulating the gland properly, if the problem is with the ACTH, if the ACTH, not stimulating properly, if ACTH is has increased action, so then we call it as Cushing's disease. If the problem is because of the adrenal gland, okay, adrenal gland in the sense, sometimes adrenal gland, sometimes tumors and all in the body, or even carcinoma in the body, will secrete more steroids within them, and these steroids can also cause Cushing's, and that is called as Cushing's syndrome. Okay, so Cushing's disease and Cushing's syndrome is different, but the manifestations is the same. Cushing's disease, we say if the problem is with the pituitary gland. Syndrome, we say if the problem is with the adrenal gland, and also because of tumors or any other cancer cells and all produced in the body, that will be secreting, or because of medications and all. When the client is on lifelong steroid medications also, Cushing syndrome can happen. Okay, so that is Cushing syndrome, we say. And there is a test that is done to distinguish this. That is called as dexamethasone suppression test. Okay, so this the dexamethasone, this one will be given. I'm not going deeper into that aspect. So dexamethasone is a steroid. Okay, so when actually like when dexamethasone is given, so like if the client is not having if the client is not having Cushing's disease, the steroid should be low in the morning. Okay, so if the client is not having Cushing's disease, the steroid should be low in the morning. Even after giving dexamethasone, if the steroids are high, then that is indicating Cushing syndrome. Okay, so don't worry too much about that. Just remember there is a test called as dexamethasone test that is usually done to distinguish between Cushing's syndrome and Cushing's disease. Okay, but mainly for NCLEX, you need to know what are the assessment findings. See here, so mainly these findings. Okay, the client will be having, you need to learn the electrolyte imbalances very importantly. Okay, so electrolyte imbalance, moon phase, buffalo hump. Okay, so ecchymosis, the skin becomes thin. See here, in Cushing's, increased steroids that will be causing hyperglycemia, increased corticosteroids, hypernatremia. These increased will stimulate aldosterone, also causing excess removal of potassium from the body, causing hypokalemia and hypocalcemia. Okay, and fluid, when it is more retained in the body, causes hypertension. So all the electrolyte imbalances are opposite to that of Addison's disease. Okay, so remember, electrolyte imbalances are opposite to that of Addison's disease. Please don't get confused there. And you know, when steroids are more, so that will be affecting the bones, ending up in osteoporosis, pendulous abdomen, thin arms and legs, muscle wasting is more here. Okay, so thin skin, easily bruisable skin, moon face, and buffalo hump. You can see here, this is buffalo hump. Okay, so buffalo hump. And also this, when there is hyperglycemia, you know, so that can cause, this condition is called as acanthosis nigricans. ACANTHOSIS, acanthosis nigricans. NIGRICANS. Okay, so when too much of when the insulin starts getting resistant in diabetic client and all, you will be finding this darkening around the neck region, in the armpit and all, you know. So that is called as acanthosis nigricans. Severity indicates the client should be checked for Cushing's disease. Okay, that is Cushing's. Is that clear? Okay, so these are the manifestation, mainly the electrolyte imbalance you need to focus here. So now you can, both conditions you can get dietary related questions. Now, may I know what kind of diet should be followed here? Which electrolyte should be increased? Yes, quick. Which electrolyte should be increased?
Calcium and potassium.
Potassium and calcium, isn't it? So even protein also, because lots of muscle wasting is there, so protein also, whereas sodium should be decreased in the client. Okay, meanwhile, since body retains more fluid, you should be assessing for so intake and output. You should check, because it can cause all the, you should check for the signs and symptoms of fluid excess. Signs and symptoms of fluid excess. Okay, like fluid excess. What are the signs and symptoms of fluid excess? Like distended neck veins, congestion, crackles. Yeah, you need to check for those. Okay, yeah, exactly. And if pituitary is the problem, pituitary is causing increase, then we go for hypophysectomy. If adrenal gland is secreting more hormones, then we go for adrenalectomy. Okay, if for Cushing's disease, hypophysectomy. For Cushing's syndrome, usually adrenalectomy. It goes like that, depending upon the cause. Okay, yeah. And also that after this adrenalectomy and all, the client may be on glucocorticoid therapy. Okay, and remember, sometimes the client, because of increased these problems, you know, thromboembolism, you should be monitoring for thrombo related problems also. Okay, so blood clotting can usually happen. Thromboembolism is another problem. Okay, yeah, so these are the aspects under the Cushing's disease. High BP, fat pads are usually developed. Okay, red cheeks, pendulous abdomen, so, and also stretch marks, red striation. See here, because of increased sugar level, wound healing is also reduced. Okay, because of increased sugar level, wound healing gets reduced. So these are the features of Cushing's syndrome. Is that clear? Hope you understood the difference between Addison's disease, Cushing's syndrome, okay, and Addisonian crisis is severity of Addison's disease, okay. And there is also another crisis, we call it as adrenal crisis. Adrenal crisis is when when adrenal after adrenalectomy, suddenly the adrenal the hormones gets reduced, isn't it? So that is called as adrenal crisis, okay. So don't get confused between adrenal crisis and Addisonian crisis. Both are different. Both are different. Is that clear? Okay, so both are different. After adrenalectomy, the crisis develops as adrenal crisis. That is because of sudden drop in the cortisol level. Sudden drop in cortisol level causes adrenal crisis, which can be manifested as low BP, hypotension, tachycardia, tachypnea, and all. Okay, so that is adrenal crisis, we say. So where you should also check for the incision site and all. Adrenal crisis, any stress, any adrenal hemorrhage can all trigger for adrenal crisis. Okay, so that is one you need to know. Okay, yeah, so hope that was clear to you. So these aspects. So coming to the next condition called as pheochromocytoma. Pheochromocytoma. But before that, I would also like to talk about another syndrome that is called as Conn's syndrome. Conn's syndrome is increase in this one or hyperaldosteronism, we say. So that is Conn's syndrome. Okay, so hyperaldosteronism. I'll just open that slide. Yeah, so in Conn's syndrome, what happens is the mineralocorticoids become highly to excess. Okay, and usually it is caused by adenoma, any tumors and all. The mineralocorticoid, see, glucocorticoid only more is Cushing syndrome. Mineralocorticoids excess is Conn's syndrome. Okay, so there is excess secretion of aldosterone. This aldosterone excess will be causing sodium and water retention and potassium excretion. The client will be having hypertension, hypokalemia. Please note these points. Hypertension and so mineralocorticoids. Aldosterone is very, very high. So in that case, what will happen? So there is more sodium, more water. Okay, so causing and also increased excretion of potassium from the body. Is that clear? So that is Conn's syndrome, we say. Okay, for Conn's syndrome, you need to specifically monitor the blood pressure, potassium, sodium, and hyperkalemia, and you can give some this one like usually what happens is when more and more actually this one gets removed from the body, you know, so the potassium gets removed. Okay, so that is usually there, but the clients who are having renal problems, for them the potassium can again be retained. Okay, for that you will have to monitor further. Everything is in several aspects, it is indirectly related. Potassium, kidney related problems, potassium will not be, because of the problem in the kidney, the potassium will not be removed. In those cases, again, hyperkalemia will be there, not hypokalemia. Okay, so all those aspects you should be monitoring. And further, the client can go in for adrenalectomy. Okay, so adrenalectomy is the surgery that is usually done. Okay, after adrenalectomy, so what happens is all of a sudden the blood pressure can drop. Okay, so that is also a problem. So if blood pressure drops, the client can end up in hypovolemia, hypovolemic shock. Okay, so that is very importantly, that is called, I mean, so you need to focus on adrenal crisis. Okay, when suddenly when adrenal actions gets decreased, you know, so especially after adrenalectomy and all, so that is called as adrenal crisis, and the client should be monitored for that. Okay, yeah. So cardiovascular collapse, hypotension, shock, can happen if the this one catecholamine levels drop. Okay, so this catecholamine levels are mainly present in the medulla. Okay, so this treatment is for another condition also that is called as pheochromocytoma. Okay, see, in Conn syndrome, mainly when the adrenal glands get removed, the BP gets reduced. That is one thing that you need to monitor. Whereas, what is this catecholamine? Catecholamines are a kind of enzymes that are present, that is responsible for increased adrenaline and noradrenaline response. Okay, so now when a tumor is there in the medulla, that is pheochromocytoma is a tumor in the medulla. Okay, so this tumor, when we can remove it usually by adrenalectomy. And at that time, the catecholamine levels can drop suddenly. Okay, so probing the client for this cardiovascular collapse, hypotension, and shock. Okay, so pheochromocytoma is a tumor in the adrenal medulla. Conn syndrome is increase in the mineralocorticoids only. Pheochromocytoma is a tumor in the adrenal medulla. Okay, so adrenal medulla is mainly responsible for producing adrenaline, noradrenaline. When tumor arises there, the release increases, causing increased hypertension. Okay, because of pheochromocytoma, the client can end up in stroke, hemorrhagic stroke, too much of high blood pressure. Okay, so can be there. So therefore you need to monitor for the blood pressure very importantly. Okay, so that's very important. Okay, so that's very, very important. So please understand about this pheochromocytoma. Okay, hormone secreting tumor that occurs in the adrenal medulla. It releases too much of epinephrine, norepinephrine, or adrenaline, noradrenaline. So these hormones are responsible for controlling the heart rate, metabolism, and blood pressure. Okay, so we can assess this problem by going in for a 24-hour urine collection test for VMA. That is vanillyl mandelic acid test, we say. Okay, so in that test, the level of catecholamines will be measured, and that is why high levels indicates tumor, and that's why we go for 24-hour urine collection test. Okay, surgical removal is the primary treatment, so that you need to know. Fine, so surgical removal is the primary treatment here. Okay, so please note for hypertension, which I already discussed, headaches, palpitation, and all. So these are very, very important points. Okay, and further, if it is not treated, the client can end up in hypertension, retinopathy, nephropathy, cardiac enlargement, dysrhythmias, and so on. Okay, so therefore, so these points are really the important ones in regard to the pheochromocytoma and also the entire adrenal gland disorders when we consider the adrenal gland disorders. Okay, yeah. So that was about the adrenal gland disorders. Any confusion? Full of confusion? Yes. I see if you systematically write down the points and make notes of your own, so please make notes of your own. So that's very important. Okay, so make notes of your own through which you will be clear. When you make notes of your own, so you will be able to understand because you know what your mind says, and that what your mind says you will be writing down. And when you make notes of your own, so it will be easier to remember the points. Okay, so therefore don't focus on anything else, refer the lectures and make notes of your own. So that's very important. Okay, and meanwhile any confusion or doubts also, so you can ask. Yeah. Moving to the next part is endocrine medications. Okay, endocrine medications. Here I will be discussing a few medications and how the impact of the same and what all you should be, especially you will be assessing there. Okay, so we are only going because endocrine medications is one or two specific points. If you know, I believe that could be more than enough. Okay, yeah. the first set of medications that we are going to discuss is pituitary medications. These are a few names of pituitary medications. Okay, so it's difficult to remember, but still, so these are a few names of pituitary medications. Okay, so how are they going to help? Like usually these pituitary medications are given when there is hypopituitarism, isn't it? So they will increase the level of hormones and thereby it will help in the growth also. Mainly when growth hormones are given, especially in pediatric clients and all, so growth hormones are usually given, and you need to monitor for certain aspects. That's very important there. Okay, so growth hormones are used to treat pediatric or adult growth hormone deficiency, treat acromegaly and all. Okay, the side effects are like hyperglycemia, hypertension, mainly weight gain. Apart from that, so you should note for the child's physical growth. Write down this point. The child's physical growth should be assessed. Okay, so and you need to compare it with the standards. Fine, and also you should be assessing everything, blood vital signs, blood glucose levels. Okay, so you should teach about the manifestation of hyperglycemia and everything. So you need to focus on these aspects when growth medications are actually given. So is that clear? So mainly focus on these points under the endocrine pituitary medications, mainly when it is given. So the growth factor should be assessed very importantly for pituitary medications. Okay, yeah, and also the family should be taught about the signs of hyperglycemia, and blood tests should be done, and also they should be taught about the periodic blood test, importance of periodic blood test. Okay. Next comes antidiuretic hormones, mainly desmopressin acetate and all. What do? They basically antidiuretic. They make sure that the reabsorption of water is happening. Okay, and therefore the side effect can be hypertension, water retention and all. So you should note for that. So remember the side effect: water intoxication, headache, hypertension, nasal congestion. So these are the side effects of these. Okay, so you should be monitoring for this. You should be monitoring for these side effects very importantly. Okay, yeah, so water intoxication, drowsiness, all those side effects you should monitor. Just remember these points. That's more than enough. Okay, yeah. Moving to the next one, thyroid hormones. So these are a few thyroid hormones like levothyroxine sodium, liothyronine, Liotrix, and there are also anti-thyroid medications like propyl, which is used for hyperthyroidism, iodine solutions, methimazole and all. So we are generally using for hyperthyroidism. Okay, yeah. So thyroid hormones, what do they actually do? Like they accelerate the metabolism. So that is what these thyroid hormones do. But you need to remember, so these thyroid hormones, okay, so they should be given at least 4 hours apart from multivitamins, aluminum hydroxide, all antacids. This you generally know. Thyroid hormones are usually taken separately early in the morning in an empty stomach. It is not because it should not be mixed with any food or like taking along with other foods can cause a decreased absorption. Okay, yeah, that is one thing. Then these are the other 2 points. They enhance the action of oral anticoagulants, sympathetomimetics, which increase the sympathetic nervous system, the actions, and antidepressants. Okay, which means that when a client is on thyroid hormones, antidepressants action and all will be great. It will be too much. Okay, whereas when a client is on thyroid hormones, so the insulin, oral hypoglycemic, digitalis actions can be reduced. Okay, when thyroid hormone is there, you should be monitoring for bleeding. You should be monitoring for mood changes. Okay, so bleeding is very important because action increases, and antidepressant dose also should be monitored. That is one thing. Okay, you should be checking for the blood glucose level because blood glucose level may not improve with the thyroid hormones. That should be checked properly. Okay, so is that clear? So that's about the thyroid hormones very importantly. So you need to know the important points. Okay, yeah. So then apart from that, so the client should be taught about hyperthyroidism also. That's there, isn't it? So when a client is using antithyroid medications, the side effects are many, like toxicity can happen, iodism can happen, some iodine solutions are there. So you need to know the characteristic sign of iodine poisoning. Okay, iodine poisoning. So iodine poisoning, iodism. So what is this iodism? So iodism usually is iodine poisoning, we say, where there is vomiting, abdominal pain, metallic taste, sore gums, and salivary glands. Okay, so this is these are the aspects under the antithyroid. See, and when a client is on antithyroid medication, so instruct to take pulse and all, because see, checking pulse is very important here. So because it can, antithyroid can cause low the effect when it is great, you know, the thyroid reduces, causing bradycardia and all. So antithyroid effects to be monitored, so through checking the pulses regularly. Okay, and also you should be avoiding all the medications that contain aspirin and all, because aspirin and all, already these aspirin effects and all go high, so the client may be at a risk of bleeding. Okay, so therefore, so these aspects so you should be monitoring for, right? Coming to the next aspect, parathyroid medications. Parathyroid. Okay, so and parathyroid medications, it's very simple, like calcium acetate, calcium carbonate, calcium gluconate. These are the calcium supplements. So vitamin D supplements are vitamin D3, ergocalciferol. So these are vitamin supplements. Okay, so biphosphonates and calcium regulators, they make sure that the biphosphonates, what do they do? That's usually given in osteoporosis and all. They make sure that the bone resorption is stopped or it is decreased. Okay, alendronate, calcitonin sodium. Okay, ibandronate. So these are important. They will preserve the functioning of the bone. Okay, yeah. And these are the medications for hypercalcemia. Remember, calcitonin, paricalcitol, sinacylate. Okay, so just doxycalciferol. So they are the medications for hypercalcemia. The supplements you need to know. Okay, and also the medications for hypercalcemia. That's it. Okay. And all other aspects are the ones based on the signs and symptoms. You should be focusing on the same. Okay, yeah. Coming to steroids. Steroids are basically in different forms, isn't it? So now steroids are usually given as for Addison's disease mainly. So when steroids are given, you should be checking for its side effects. See, for Addison's disease, when treatment is done, you should be monitoring for the signs and symptoms of Cushing's disease. Okay, when for Cushing's disease medication is given, you should be monitoring for the signs and symptoms of Addison's disease. That is what you need to remember here. Okay, like for example, when a client is on these drugs, okay, so when a client is especially on high fluorocortisone and all, glucocorticoids and all, cortisone, dexamethasone, hydrocortisone and all, so you should check for what? Sodium, hypernatremia, hypokalemia and all. Okay, do you understand? So hope you are understanding. You should be monitoring for its excess effects. So that's very okay. Yeah. So similarly, there are androgens, testosterone, different kinds of testosterones are there. So they all come under this one itself. Remember, steroids are usually taken with food. Steroids are usually taken with food. And when steroids are given, the client should be instructed to take diet good in potassium and all. Okay, so that's also normal. Fine. Okay. So these are some of the the other medications, estrogen, progesterones, and all. Just you can just note down the names. Estrogen, I mean, so estradiol, megestrol. So they are certain names. That's it. Okay. So they are not going to bother you very much. I suppose they are not going to bother you too much. These drugs. Okay. So estrogen, progesterone, and also for when a client is on hormonal replacement therapies and all, so they are basically on these treatments. Okay, so estrogen treatment, progesterone treatment, and all. So you can get questions in the sense like mainly the what should be contraindicated, or when should be estrogen contraindicated. Mainly you should note down that when a client is having history of endometrial cancer, thromboembolism. Okay, so remember see this estrogens and all are actually they enhance the clotting factors, or the clots, not clotting factors, the clots gets enhanced when estrogens are taken. Okay, so the client can end up in thromboembolism, so that should be monitored very importantly. Okay, and also when estrogens are taken, if the client is on phenytoin and all, the effectiveness can be reduced. Phenytoin, so which is an anticonvulsant, so the effectiveness can be reduced. So therefore in that way you can so the questions you can get there. Okay, yeah. So estrogen, yeah, so these are use in caution. These are some contraindications: breast cancer, endometrial cancer, history of thromboembolism. Okay, so use caution in clients with hypertension, gallbladder disease. Increase the risk of toxicity when used with hepatotoxic medications. Okay, barbiturates, phenytoin, rifampin decrease the effectiveness of estrogen. Okay, so that is what we were discussing. Fine. So these a few points, 2 or 3 points only you can note down. That's enough. Okay, yeah. So that's it. And the medications for diabetes mellitus and all we had discussed. See, under the hormones itself, I would like to talk about contraceptives also. Contraceptives are usually taken for 21 days and then stop for 7 days, and then the cycle is repeated. So now for people who are smoking or hypertension, so they are it's better to avoid contraceptives because it can usually it also has got a risk factor of developing clots. People or women who are hypertensive, thromboembolism, coronary diseases and all, for them the use of contraceptives are contraindicated, remember. Okay, and also if the client is on any aspirin or hepatotoxic medications, the contraceptives are contraindicated basically. Okay, and while on contraceptives, the client should be monitored for bleeding and all. Okay, and especially when certain antibiotics, so specifically which was that antibiotic we had discussed, wherein the birth control pill, when even if on OCPs, added birth control measures have to be carried out. Any idea? Do you remember which was that? Yes, forgot? See, pharmacology, the slides have been uploaded already. Yeah, so which was that antibiotic, so which needs to be wherein even if the client is on OCP, oral contraceptives, if she's on that particular antibiotic, so she will have to take added birth control measures, or she should carry alternative form of birth control. Which was that? Tetracycline. Very good. Okay, so tetracycline. See, the pharmacology PDF has been uploaded. You can write down the important points, and don't write down everything that is there in the slide. Okay, so only the main points that I had discussed in the class, you can just note down the same. Fine. Under medications, it has been uploaded, so please try to write down only the main points. So indirectly you can get many questions based on that. Okay, yeah, and tetracyclines mainly. So not only tetracyclines, mainly the client should be taking added birth control measures. But even if generally antibiotics, when a client is on antibiotic, and if she is also on OCPs, oral contraceptives, it is better to take an added measure for birth control. Okay. So this education also you should be giving. Fine. Okay. And suppose if the client wants to discontinue contraceptive for becoming pregnant, okay, tell her she should follow, after stopping contraceptive, she should be taking up another another method. She should follow another form of birth control for at least 2 months before she gets pregnant. Okay, so that's very important. Like if she decides to discontinue the contraceptive to become pregnant, okay, you should recommend alternative form of birth control for a minimum 2-month period. So because that will be the period where the hormonal effects would be removed from the body. When a client is pregnant, so so immediately if she becomes pregnant, the hormones are still there in the body. The hormones that was gained through OCPs, through oral contraceptive, that is still there in the body. Okay, so therefore immediately if she becomes pregnant, so that will have a greater effect on the baby. So therefore, after stopping oral contraceptives, you should educate to carry out another birth control measure for 2 months before she gets pregnant. Okay, so that's very important. Fine. And also on contraceptive patches, you can get some questions. There are contraceptive patches that is used for 4-week cycle. Okay, 4 weeks contraceptive. So it is attached. One patch, it's attached for 4 weeks. So that patch will have a contraceptive effect. Now, sometimes this patch can come out of the body. In that case, if the patch is out of the body for less than 24 hours, she can reapply the same. Okay, for more than 24 hours, if it was out on the body, so then she will have to carry a new 4-week cycle contraceptive patches. 4-week cycle she has to carry. That means again once more she will have to start it. Okay, yeah. So is that clear? So these are the points that are somebody mic is on. Yeah. So these are some main points of NCLEX. That's it. So we are not going to focus too much in depth of the same. So they are only related with NCLEX points. That's it. Okay. And that was all about the medications. Fine. So let us do a few more questions now. So the nurse is performing with a morning dose of Glargine and it's scheduled and a scheduled fixed dose of Lispro with meals. Before breakfast, the client's finger stick glucose is 105 mg per deciliter. The tray is in the room and the client is eager to eat. What action should the nurse take? Administer both insulin as prescribed, hold both Glargine and Lispro, hold Glargine, hold Lispro. So these are the options that are given. Glargine is what basically? It's a
long acting.
long acting. And what about Lispro?
It's rapid
acting.
Lispro
Rapid
is
acting.
rapid.
Rapid.
Exactly. Rapid acting, isn't it? Okay. So now therefore, so what are you supposed to focus here?
You give the two of them.
First one.
Administer both insulin as
The both of
prescribed.
them.
Yes, exactly. So that will prevent hyperglycemia along with the consumption of food. Okay, so holding Glargine will increase the blood sugar level and holding Lispro will be causing the blood sugar level to rise suddenly. So therefore, so both has to be given and therefore option 1 is considered as the right answer. Okay, very good thinking. Yeah, so we'll move to the next one. The nurse assesses a client with Cushing's syndrome. Which clinical manifestation should the nurse expect? Select all that apply. It's very easy.
It's hyperglycemia, hypertension.
Okay.
and truncal obesity.
Okay.
Yeah,
Hyper-
that's it.
One,
That's it.
two, four. One,
Yeah.
two, four.
Exactly. Okay. So 1, 2, and 4 are the right answers. Okay. Fine. So 1, 2, and 4. That's all about today's session. Any doubts for clarification? So time for doubts. See, please write down your notes. Okay, so please hypo and hyper in every conditions. In adrenal, you can divide your pages into 2 in your book. Okay, and hypo and hyper. So what all happens in the case of adrenal adrenal gland disorders? Hypo will be causing what problems? How are the electrolyte levels? The management. Okay, the medication. So similarly, hypo. So what are the main signs and symptoms? The electrolyte levels, the main interventions, and the medications. So divide your pages into 2, and that's how you need to learn the endocrine disorders. Okay, apart from diabetes mellitus. So this is how, and that will be really helping you out. Okay, yeah. So is that clear?